All right, good evening to everyone. Bienvenue à toutes et à tous. To those in person and online, welcome to the Osler Library. I want to start by acknowledging that McGill University is on unceded lands, which have long served as a site of meeting and exchange amongst diverse Indigenous peoples. The Kanien'kehá:ka and the Anishinaabe are recognized as the traditional stewards of the lands and waters on which Tiohtià:ke, Montreal, is located. The Osler Library, where we are now, opened in 1929 in the room behind me. It was bequeathed by Sir William Osler to the medical faculty of McGill for the medical profession of Canada. And Osler took special care to specify that its doors be open to students, to his French-Canadian colleagues at Laval and beyond. And we do our best now to continue that open and inclusive vision, welcoming scholars from around the world while doing what we can to inspire and engage medical students here at McGill. And with that in mind, rather than occupying the podium, I'm going to hand the mic over to Saruchi, a member of the McGill Medical Students Osler Society, who will be your MC this evening. Saruchi.
Hello, everybody. Thank you, Dr. Earl. So my name is Saruchi. I'm a second-year medical student at McGill, and on behalf of the Board of Curators of the Osler Library of the History of Medicine, as one of the members of the Medical Students Osler Society, I welcome you tonight. So tonight we'll be hearing from many worthy candidates addressing topics from a broad variety of subjects, which we're excited for you to hear from, learn about, and get inspired about. So this event is made possible by the generous gift of Pamela and Rolando Del Maestro. Dr. Del Maestro's immeasurable contribution to all paths of his passions is sure to impress. Having retired as the director of the Brain Tumor Research Center and from his clinical practice in brain tumor surgery in 2012, Dr. Del Maestro currently devotes his time to advancing novel techniques, education, and preserving historical artifacts. Here we have Dr. Del Maestro as a chairperson of the Standing Committee of the Osler Library of the History of Medicine at McGill. He would like to share a few words with you. The floor is yours, Dr. Del Maestro.
First, thanks everybody for coming. I know it's always interesting to come to these events, but starting at 5:30 and going on a little bit further, sometimes that's an issue, especially for the medical students, because some of them have had some difficulty getting the time off their courses. But the first thing I think Pam and I would like to do is to congratulate all the individuals who are going to give presentations today. And my feeling is, we'll let Pam do the rest.
Well, I always think the topics are so exciting, and there's so many people, researchers, scientists, doctors, but also friends and people all over now that it can be on Zoom who can hear your stories. They're just fascinating. I love to hear all of them, and I love how it ties in medicine with humanities and so many other issues. So many people think medicine is just surgery or giving pills. It's so much more, and that's what the Osler Library embodies, and that's how we feel about it. So good luck, all of you, tonight.
And I think the only other thing I want to say is the Osler Library is sort of like a bridge. It's a bridge between medicine and a bridge between the humanities. And that's a very important bridge. And let's just keep that bridge open and keep it as wide as we possibly can. Thank you very much.
Thank you very much to both of you. So I guess now we'll start with the essay contest, which each presentation will be followed by a very brief question period. And then after that, we're going to have our Molina Scholarship awardees present, again followed by a brief question period. During the presentation, if you happen to have any questions regarding the topic and you're streaming in, please don't hesitate to reach out to us using the email address osler.events@gmail.com or contact us via Twitter at Osler Library and hashtag Osler Essays 2023. You can also raise your hand if you're present in the room with us today. So without further ado, starting the presentations, here we have Amina. Amina is a second-year medical student. She previously completed a master's in epidemiology at the University of British Columbia and worked in public health before returning to Montreal for medical school here. Amina, the floor is yours.
Hello. Thank you all so much for being here today. And thank you, Dr. Hagerl. can't see you anymore, but thank you for organizing all of this. Yes, my presentation, or my essay was titled The Opioid Overdose Crisis in British Columbia, Towards a Socio-Political Reckoning. And this was really a sociological analysis and essay. After my master's in epidemiology, I worked as an epidemiologist, and I became very interested in sociology and took some courses at UBC, so I thought that it would be an appropriate topic. So a bit of an introduction. The essay really delves into the opioid overdose crisis in BC. So the crisis began, or overdoses began rising quite sharply in 2012 in BC, and a public health emergency was subsequently declared in 2016. And now illicit drug overdoses are the leading cause of death in BC for individuals ages 10 to 59. And while a number of interventions have been introduced to curb the deaths, 2023 is actually on track to be the worst year in BC's history. So I wanted to give a very general overview in this presentation. It's hard to go into the details of the essay here, but the essay was really divided into three big parts. So the first, I sought to understand the history of opioids in BC and opioid dependence. In the second part of the essay, I wanted to understand the current theories of addiction. I use addiction and dependence interchangeably in this, in the essay and in the presentation, that inform the policies and interventions that have been introduced in BC. And then in the third part, I kind of hone in on the sociological theory that explains addiction and dependence. And I try to understand why our policies in BC have been not meeting the needs of the population and not led to even a kind of higher level decrease in overdoses and overdose deaths. So the first part of the essay, kind of the history and how did we get to this crisis. So as I mentioned, the crisis has been going on since the early 2010s, but since 2016, almost 13,000 people have died of opioid-related drug overdoses in BC. And research has demonstrated a number of factors associated with the deaths. So men ages 39 to 59 are especially at high risk, and also those who have experiences with poverty, mental health issues, substance use disorder, trauma, and those lacking social supports are especially at high risk of death. So opioids generally, what are opioids? They're substances derived from the opium poppy. Many of you are likely very familiar with them. They're used medically or in medical settings very regularly to treat indications of pain. They've been used therapeutically and recreationally for thousands of years. Actually, even in Dr. Osler's writings, he has a paper where he writes about having a renal stone and the pain that he experienced with his renal stone and refers to opioids as God's own medicine. And actually, Canada was, as you know, while we still use opioids regularly in medical settings, Canada was one of the first countries to ban opioids for non-medicinal uses. And that was following kind of moral panic due to drug use and its impacts. And the photo there is just of Dr. Osler's writings on his renal colic. So a bit of a timeline in British Columbia. So 1907 is when the first anti-Asian sentiment and moral panic grew due to drug use against Chinese and Japanese rail workers, especially in Vancouver, who are using opium recreationally. In 1908, the government banned opium as a result of the riots. In the 1960s, around the 1960s, some earlier, other countries began to ban opium, and I'll go into this a little bit, but it was largely a change in kind of cultural norms and cultural feelings about drug use. And then in BC in 2000 was, in BC and North America widely, there was a rising number of opioids prescribed for indications of pain. And then subsequently, an effort to curtail those the opioid supply in the public. And then in 2012 is when we really started to see an illicit supply proliferate, especially in BC, including the opioid fentanyl, which is a synthetic opioid. And then 2016 was the declaration of the overdose crisis in BC. So in part 2 of the essay, I go through there are many theories of addiction, many models out there, but I go through 3 kind of big ones in my mind. The first being the moral theory. So essentially, countries began banning opium because around the time of the temperance movement and led by the Methodist Church, the public began to see alcohol and drug as a moral issue. So people believed that consuming drugs was an indication of moral decay, sin, a breakdown of social order. And this led to some moralistic stigma. So drug-dependent individuals were then seen as regarding discipline and being morally devoid. And actually, this picture on the right is supposed to be on the next slide. That's my bad. So I'll come back to it. The second theory is the most prevalent theory that we use today in medicine, and that's of the brain disease model of addiction. This is kind of developed over time, but essentially, physicians began arguing for a neurobiological understanding of addiction. And they said that it's actually a brain disease characterized by drug seeking and use that is compulsive. And now you can find this disease in DSM criteria. It's something that we learn about actually just today in our classes for the Med 2s. And they emphasize the role of genetic and neurobiological factors. And this actually really helped to reduce moral stigma because in the public's eyes, instead of it being an issue of moral decay or sin, it became a neurobiological disease beyond an issue of morality or culture. And then the last theory that I look at in the paper, and the one that the paper is really designed around, is the dislocation theory of addiction, developed by Bruce Alexander, who is a sociologist in BC. And he believes that social and economic forces beyond the control of the individual actually work to alienate and dislocate individuals from structures of meaning. And as a result, addictive behaviors are an adaptive response meant to fill a void of purpose and meaning. So into the, and the picture that I had here was The Narcotic Drug Problem is actually a book that is available through the Osler Library, and it's an early physician who really promoted the theory of the brain disease model of addiction, and his writings were very interesting. So into the third part of the essay. So essentially, I wanted to look at the prevalent model, so the brain disease model of addiction, and apply it to the situation in BC. So as a neurological problem, a neurobiological problem, the brain disease model of addiction really prescribes a neurobiological solution. And this has led to several interventions in BC. The main one are opioid agonist therapies. So this is the use of opioid agonists such as Suboxone and low-dose morphine to help decrease feelings of desire for the opioids for opioid-dependent individuals. And then there are several harm reduction strategies that have also been introduced. So take-home naloxone is an antidote for opioid overdoses that can be administered by a bystander. Supervised consumption sites are locations where an individual can go and use drugs while being supervised by a medical professional who can respond to the overdose if it happens. And several kind of decriminalization processes are underway. So right now in BC, simple possession of a drug is decriminalized. So you won't be arrested and taken to jail essentially for having a personal possession or a personal amount of opioids on your person. So nevertheless, BC has put a lot of money into these interventions, but overdoses and overdose deaths continue to rise. And I wanted to think about why, but through a sociological lens. So essentially, OAT availability, it's quite widely available now in BC, but it hasn't correlated with decreased rates. And actually, in studies done on OAT, only 60% of people who are begun on the therapy complete induction, which is the first process, and then only half of those will actually go on to the maintenance phases of OAT. So there hasn't been that much uptake. And then the harm reduction interventions have been great in that they have definitely helped avert deaths, but harm reduction is just that. It aims to reduce harm. It doesn't aim to address opioid dependence in and of itself. It just aims to have people who are opioid dependent have a safe supply of drugs and have a way of surviving kind of through the days in order to then perhaps seek other services or seek help from their doctors. So this comes in the dislocation theory of addiction. So increasingly, there is discussion about how the brain disease model of addiction doesn't properly address the crises that we're seeing not only in BC, but across the Western world. And it also, the BDM doesn't, in BC, it doesn't explain the overdose crisis in that most people who have overdoses and who die of overdose deaths haven't had a previous prescription of opioids. So the theory that overprescribing of opioids caused dependence in the population is it's not that well substantiated. And so the dislocation theory suggests that our economic model, increased privatization, competition, and economic individualism isolates people from structures of meaning, and they seek drugs as a way to adapt to their current environment in our society. So generally, the BDMA will suggest a individualized cause and response, while the dislocation theory will suggest a structural cause and a structural response. So understood through the dislocation theory, current policy in BC only further isolates and burdens individuals with their care. And it does suggest that in order to decrease overdoses in BC, we need higher level structural interventions. So a broad conclusion to the essay and presentation. So opioids, again, have been used recreationally and therapeutically for thousands of years. The brain disease model of addiction has helped reduce temperance-era moralistic stigma around drugs, but has not produced the interventions that we hoped would decrease overdoses and overdose deaths. And the dislocation theory of addiction suggests that social and economic determinants of drug use and dependence may be the only interventions that work rather than individualistic interventions. Here are my references, and that's it.
Thank you, Mina. I'm just going to say from here, do we have any questions from the audience either online or anyone in the room with us today?
Yes.
Why do you think the model in Portugal has worked so well? You know, what is the difference between the model in Portugal compared to the United States or Canada?
I think it's a really good question. I think the model in Portugal is really unique in that it's, for those who don't know the model in Portugal, essentially they've decriminalized drugs in that if law enforcement finds a person using drugs or finds a person in possession of opioids, for instance, they won't be put in jail or in prison, but they will be kind of compelled to find social services or go to meetings in order to address their dependence or the reason why they're using drugs. So in my personal opinion, and I don't know the literature well enough to know, but my personal opinion on this is that in Portugal, when if someone is deeply kind of street entrenched and they're using drugs, they're still being connected to social services. So instead of putting that person in jail and punishing them for using drugs, they'll be connected to services to address the issue of dependence. Whereas in Canada now, the model is really to decriminalize, but there's no real way for that person to be connected to the social services after that. So it's kind of like if an ambulance, and I kind of go into this in the essay as well, if an ambulance or a police officer finds someone using, the answer is really to just leave them. So in that way, someone who's opioid dependent isn't ever going to be connected to the healthcare services that they need to address their dependence, whereas in Portugal, they will be. So I think that's in my mind, that is the main difference, is that it's less of an abandonment of the individual to just do as they will on their own accord, and it's a recognition from the state that these individuals might actually need help, and the police can actually be liaisons to identify those people and connect them to the services that they need.
Thank you. Is the increase in opioid deaths and overdoses specifically related to fentanyl, or is there some other factor?
So it's a good question. So at the beginning of the overdose crisis, that was the main theory, was that the overdose death crisis was really a response to the illicit supply of fentanyl that was entering the population. But now actually, in the years since this has begun, there's been quite a bit of research into, essentially the theory was that people's usual drug supply was being laced with fentanyl and they're accidentally overdosing, whereas they were looking for heroin or some other opioid. But now actually the research shows that a large proportion of people will actually seek fentanyl. They're using fentanyl knowingly, and so that has changed a bit. And the character of the overdose crisis has changed as well, where benzodiazepines are now a larger issue that is coming. So I think that the predominant belief is still that fentanyl has a large part to play, but probably I think less so now than we previously thought. Yes.
I was curious, I just Googled opioids in Quebec. Mm-hmm. Oh, sorry. So I was just curious, sorry, I'm loud, and I Googled opioids and Quebec. So it turns out the Quebec government just tabled a bill it says to allow it to join a proposed class action lawsuit against more than 40 pharmaceutical companies and retailers who are accused of downplaying the harmful effects of opioids. So,
yeah, I think in Canada and North America, the theory is still, and I do believe that this is true, that overprescription of opioids did cause increased circulation of opioids. I think that, in my mind, the theory is that it's not, I think the character of drug use kind of changes even from city to city within Canada, but the drug seeking, I think it can't be completely explained by pharmaceutical companies and availability of drugs in the population. I think that the character of the drug seeking is probably needs a larger explanation.
Thank you, Amina, for a very informative presentation, and thank you all for your questions. So now we'll move on to Megan. Megan is also a second-year medical student here at McGill, and she's formerly a MedP student who's had an interest in humanities for a very long time. She spends her free time, amongst other things, writing, which is an interest of hers, and that's what brought her in today with us. So go ahead, Megan.
Is this okay? You guys hear me? Okay. Hi everyone, so my name is Megan. I'm a Med 2 student. First of all, I want to thank the Osler Library, the Osler Society, and the Del Maestro family for making this event possible. I'm really glad I convinced myself to participate this year because I really enjoyed the process, so thank you for making it possible. Today I'll be talking about mortality in medicine, how palliative care and euthanasia reframe our relationship with death. And so over the past few years, I've been lucky enough to be exposed to the practice of both palliative care and of medical assistance in dying. And so both those exposures have led me to wonder whether we can ever think of euthanasia practices like medical assistance in dying as the logical extension of the practice of palliative care. So before trying to answer that question, I want to outline a very brief history of both disciplines. So palliative care draws its origins from the very ancient concept of a hospice, where a hospice is a home for the terminally ill. Hospices were historically run by religious institutions, but over time, as religious groups began to lose their influence and scientific medicine gained traction, the very first modern hospitals refused to admit patients deemed uncurable. And so for a very long time, dying patients had no more spaces designed for their care. Towards the end of the 19th century and through the 20th century, different religious groups and also healthcare professionals began to establish these new hospice-like institutions. And in 1967, Dr. Cicely Saunders founded St. Christopher's Hospice in London, which is known as the first modern hospice. The term palliative care itself was actually coined by Balfour Mount, a McGill urological surgeon who visited St. Christopher's Hospice and brought the practice back to North America. So throughout my research into the practice of palliative care, I came across many inspiring, innovative figures, but no one quite as striking as Cicely Saunders, who's widely known as the founder of palliative care. So she was trained as a nurse and a social worker, and eventually also became a physician. As I said earlier, she's the founder of St. Christopher's Hospice and established that institution with the idea that medicine so far had really refused to engage with the concept of death and dying, but that in fact dying patients should be cared for within the medical realm. Her vision of medical end-of-life care encompassed adequate symptom control, rigorous scientific research, an emphasis on an interdisciplinary healthcare team, and above all, the importance of developing good interpersonal relationships. Euthanasia as a discipline comes with a lot of tricky, loaded terminology, and I wish I could run through all of it, but in the interest of time, I'll just define euthanasia itself as the act of killing someone with the intention of easing their suffering. And so in this talk, I'll obviously be referring to voluntary euthanasia as opposed to involuntary euthanasia, and I'll also be talking more about the concept of euthanasia as it applies to the context of a terminal illness, so more as it relates to palliative care. And so since the very beginnings of medicine, euthanasia has been a controversial topic, with the Hippocratic Oath stating that physicians should not administer a deadly drug nor advise such a plan. So this ethos aligned with many major religions' concept of the sanctity of God-given life, and both those frameworks rejected any notion of euthanasia for a very long time. And then throughout the 20th century, there was an increase in pro-euthanasia societies, which did a lot of advocacy work that eventually led to, at the turn of the 21st century, the legalization of euthanasia in many different countries, and the practice is legal in Canada since 2016. And so there's a lot of different euthanasia frameworks that exist, but they all share some common ground in that they would grant euthanasia to patients suffering from an uncurable disease, who are in a state of unbearable suffering, who are mentally competent, and who've expressed a voluntary, repeated wish to die. Also important to note that most existing frameworks already carve out a very large role for physicians. So physicians are the ones who are in charge of assessing the mental and medical status of people requesting euthanasia, of discussing alternative treatment options, and of administering or enabling the death itself. And so now that we've established the foundation of both disciplines, we can get back to the original question. And Dr. Saunders herself was actually very strongly opposed to the idea of integrating euthanasia within palliative care. And so while it may be difficult to contest the very founder of palliative care, a deeper dive into both disciplines reveals that they're underpinned by many of the same fundamental ideas and that they challenge medicine's traditional relationship with death and dying in the same ways. And so they both share a concept of the good death, a deep respect for patient autonomy, and a commitment to the relief of human suffering. So proponents of both disciplines think that a good death is one that is not overly medicalized or technological. So until the 19th century, there were strong currents of thought within medicine that maintained that physicians actually should have a role in caring for the dying, even if they could no longer offer any concrete treatment. But then throughout the 19th and 20th century, there was huge technological advance and greater scientific understanding of disease. And so as physicians began to believe that any natural disease could be understood, diagnosed, and cured, death became this unnatural thing that was the enemy of modern medicine. And so it was thought that physicians should take these heroic, extreme measures to save their patients, and that they failed at their individual jobs when they could no longer offer any life-prolonging treatment to their patients. And so death became this unnatural thing that couldn't be addressed through medicine, and that was seen as something shameful and private. Both palliative care and euthanasia reject that narrative of shame and think of death as this thing that should be discussed, acknowledged, and explored. So dying patients are asked to think about their own idea of what a good death is, how they want to die, who they want to be surrounded with, and the extent of medical treatment they wish to receive. So to that point, both palliative care and euthanasia reject the over-medicalization of death and the prolonging of life by any means necessary. Death is no longer a failure on the part of either the physician or the patient, but rather a natural part of life and a part of life that physicians should play an important role in. Patient autonomy is a central tenet of both palliative care and euthanasia. So since the very beginning of medicine, it operated according to the principle of beneficence, which is that physicians have the duty to act in ways that will bring about the most good for their patients. Medical paternalism is kind of an extreme derivation of that idea in that physicians alone hold the knowledge necessary to bringing about good outcomes for their patients, and so can make unilateral decisions about their care. And so we can easily see how that idea of taking these extreme heroic measures to prevent death and prolong life easily fall under medical paternalism. Medical ethics was developed as a field largely after World War II and responded to this doctrine by suggesting 4 guiding principles of medicine: beneficence, non-maleficence, justice, and importantly in this case, autonomy. So autonomy as a broad concept is this idea that as rational individuals, we have the capacity to make decisions for ourselves based on our own concept of the good life. And as it applies to medicine, patient autonomy is the very basic idea that patients should have the right to make decisions about their own care. Palliative care, as envisioned by Dr. Saunders, rejected the medical paternalism inherent to the idea that physicians need to, in order to not fail at their jobs, prolong the lives of their patients by any means possible. Palliative care placed the physician and the patient on equal footing and recast the physician as a chaperone to the dying process and not as its central decision maker. Dr. Saunders asked of palliative care physicians to see their patients for the entirety of their individual selves and to guide their treatment and their death according to that individuality. So supporters of euthanasia do claim autonomy as kind of the main argument in its favor, and it's actually not totally implausible to think of euthanasia as the logical extension of palliative care's ethos of letting patients guide the terms of their own death and make their own choices about their medical care. So in the last common ground between the two, human suffering is a elusive, seemingly intangible entity that both palliative care and euthanasia seek to eliminate. So many major religions actually view suffering as a positive thing, as an opportunity for self-transcendence and for connection with the spiritual world. But medicine rejects that idea, and its goal is really the relief of pain and suffering. But defining the difference between those two things is actually important to figuring out how medicine seeks to engage with them. And so pain is a bit easier to define, and the basis for its understanding hasn't changed that much throughout time. So it basically depends on there being some kind of identifiable stimulus that causes unpleasant physical and emotional changes in the body. And so suffering is a much more difficult to define because it's this individual experience that often coincides with pain, but doesn't localize to the body and doesn't necessarily depend on any identifiable stimulus. And so as we spoke about earlier, throughout the 19th and 20th century, as medicine was being reframed as this entirely scientific and pathology-oriented discipline, pain became this physical thing that could be measured, that was tangible, and that would manifest itself in the same way across all bodies. And so the goal of medicine was to relieve physical pain with no intention of engaging with the concept of suffering. Palliative care definitely does engage with the concept of suffering and emphasizes the importance of addressing it through medicine. Dr. Saunders proposed the really innovative concept of total pain, which recognizes that the roots of suffering are multidimensional and include social, psychological, spiritual, and physical pain. And so this idea also acknowledges the fact that the roots of suffering don't have to be physical or tangible or measurable to be valid. Dr. Saunders suggested lots of different ways to address the different facets of total pain, including coming up with some really innovative opiate distribution and dosing ideas to address physical pain, and emphasizing the importance of a multidisciplinary healthcare team to address all of these different facets of total pain. But above all, Dr. Saunders really stressed the idea that the deepest suffering of the dying would only be relieved through meaningful human connection and self-realization. And so the goal of all of palliative care's medical responses to all of these aspects of total pain is really to create a peaceful, serene environment that would allow for death without any suffering. Euthanasia also kind of self-evidently believes that a good death is one without any suffering. Most euthanasia frameworks rely on the fact that people requesting it must be in a state of unbearable suffering to qualify. And so patients themselves define their unbearable suffering in lots of different terms, including loss of autonomy, loss of function, weakness, and hopelessness. And so in this sense, euthanasia aligns with Dr. Saunders' vision of palliative care by acknowledging that there are lots of different routes to suffering and that all of these routes are deeply personal and individual. However, there's definitely a break with Dr. Saunders' vision of palliative care, given that euthanasia does posit that there comes a point at which a dying person will feel such suffering that can't be relieved by any more medical treatment and that can only be relieved by death itself. And so we can finally now that we've established common ground, come back to the original question and try to answer it by looking at the real-life case example of the Flemish region of Belgium. And so Belgium was one of the very first countries to legalize euthanasia, and about a year after its legalization, the Flemish Palliative Care Federation released a very powerful statement that claimed that palliative care and euthanasia are neither alternatives nor opposites. And so this statement led to the development of the integral palliative care idea, which is a model by which euthanasia falls under the scope of palliative care physicians. And so the Federation's statement obviously stressed the importance of good palliative care at the end of life, but suggested the idea that there comes a point at which a dying patient in palliative care may feel such suffering that palliative care can no longer relieve. And so this is a very fascinating statement, and it appends lots of the traditional doctrine of palliative care that we just went through, but it does ask of the field to reflect on how its core commitments may actually align with the practice of euthanasia. And so the idea is that if euthanasia is to be legal and accepted, palliative care physicians, with their understanding of the suffering that accompanies the process of dying, their respect for patient autonomy, and their openness and honesty in discussing death may very well be the best placed people to guide patients along the process of euthanasia. And so, in conclusion, as cliche as it may sound, as human beings, we all have to come to terms with our own mortality, and as physicians, we bear a double burden because we must also come to terms with our patients' mortality. Medicine has traditionally seen death as something unnatural and shameful, as a personal enemy whom we must fight with any means and from whom we must save our poor patients. We've shielded ourselves from engaging with the profound suffering that accompanies the dying process. Both palliative care and euthanasia ask us to shed that armor. Although both disciplines are often portrayed as incompatible, they're aligned in their core commitment to providing dying patients with a peaceful death that's free of any suffering and that respects their individuality. And so there's still lots and lots of arguments against this idea that I can't go into here, and I'm not so sure I have a super conclusive answer to my own question, but I do know that this debate about whether euthanasia can be integrated within palliative care is a very contentious one, and I truly believe that the best way to approach contentious debates is to acknowledge the common ground between both sides, and so I hope I've done that today. And I also know that by engaging in this debate and asking ourselves these questions, we're forced to reflect on the values that sustain medicine's relationship to death. And I hope that we can see the truths that both sides hold, that we can realize that fighting death is a losing battle, that admitting defeat is not a failure, and that as physicians, we have the duty to face our dying patients with more compassion and humility. So thank you.
Thank you, Megan. Do we have any questions for Megan?
Thank you for a very thoughtful analysis, and I really appreciated your last statement and approach that we have to keep on thinking about this, and we need a lot of reflection. The integrative model that you described so nicely depends on both services, if you want to call them services, or both models of care being available. 7% of patients in Quebec apparently die through medical assistance in dying, and I'm afraid I don't know how many patients in Quebec receive palliative care through a specialist or someone with the expertise. And so is it possible that the number, 7% seems at least to me to be so high, is because we don't have sufficient resources for palliative care available? So we end up with a slippery slope, not through our intentions, good or bad, but rather lack of resources. And that becomes a more socio-political, to use Amina's question, about a socio-political structural problem in our society. What do you think of that?
Yeah, well, thank you for the question. I agree. I think I think Quebec, in fact, has the highest rates of euthanasia in the entire world. And I think that does reflect the fact that there isn't sufficient or good enough palliative care or good enough access to it at the end of life or throughout medical treatment in general. So I agree with that, and I think that's a real problem, but I don't think the two are necessarily mutually exclusive. I think there's ways of making palliative care better while also having a framework that allows for euthanasia. I think, in fact, one of the nice things about the integrative model is that the euthanasia and its proceedings and the way it's implemented and the way patients are evaluated for it is done through palliative care. And so when you have kind of those two coming together, then it seems that it would be much easier to figure out ways to give better palliative care because it's much more continuous and you have these same people in charge of both sides. And I think actually from what I was reading through in Belgium, for example, or in lots of countries that have legalized euthanasia and are also committed to palliative care, it seems that like you can actually develop palliative care a lot better even while having euthanasia as a program. So,
Do we have anyone else? Sorry.
Thank you. I enjoyed your presentation. I just wondered if you'd given any thought to the care of the carers, like the care of the person given the final lethal dose of medication. Have we explored the sort of resources that person might need, especially if they're doing this on a regular basis?
Yeah, I mean, that's a really good question. I'm not sure I really went into it in my essay and in my research. I think from what I've been able to see, and I'm sure we've all seen kind of similar types of things, it does, euthanasia as it applies to the end of life, and when it's well done, does seem to allow for very meaningful, dignified, compassionate deaths. And I think there could be satisfaction and meaning to be drawn from being involved in that process, even if you technically are bringing about someone's death, which is not something that's easy to accept maybe. But yeah, so I think there's ways of making those moments very meaningful and very compassionate, so that you wouldn't necessarily feel burdened by them as the physician who is participating in those moments and is responsible for bringing about death. But I think we're not, as Med2s, we're not even in the hospital yet, and I think we already have a sense of what it means to kind of have compassion fatigue and to be tired of seeing death and of seeing suffering and of seeing sickness. So I'm sure there's ways of dealing with that are similar to ways in which we deal with the stuff we see already. But yeah.
I believe we have time for one more question.
She's saying, okay.
Very informative presentation. It's more of an abstract question, but I thought about it while you were giving the presentation. When we think of death and dying, and that's really the focus of my question, we often think about preservation of memories, burial, or ceremonies people hold. Ancient times holds true for Egyptians, Aztecs, all the way to present. What relationship do you think there is between memories and the physical idea of the deceased individual? Do you think there is a relationship? And what would you think about that? It's just...
Sorry, could you
sure.
reformulate maybe?
Sure. What do you think is the relationship between memory and the physical process of dying? Do you think there is a relationship? Do you think there is not a relationship?
I'm not sure if this answers your question directly, but I think kind of coming back to my earlier answer too, I do think that there are ways in which programs like medical assistance in dying or other euthanasia programs can allow you to plan your death and plan who you want to be surrounded by and know when it's going to happen and who's going to be in charge. That can lead to some very meaningful and compassionate moments. And I think it's almost this idea of having a living funeral where people can know when you're going to pass and you can know who you're going to be surrounded by. And I think that offers a time at which you can reflect on the life you've held and share these memories. And so I guess to answer your question, I think I would say that there's this physical aspect of getting together and of knowing that physically my time is over, but I'm sharing these last moments and I'm solidifying the relationships I have and then leaving behind the memories that I want to leave behind and reflect on what's been important to me. Does that make sense? Kind of. We can talk more afterwards. I'd be happy to. Thank you, guys.
Thank you, Megan, for a very interesting topic. So now we're going to move on to Manuel. Manuel is a fourth-year medical student in McGill, again, and a writer from Montreal whose academic interests lie in the medical humanities, and they range from philosophy of psychiatry and neurology to the politics of medicine, as well as its literary inspirations. His current project is on Kant and clinical judgment. He's applying to residency and hoping to pursue a career in psychiatry. Good luck, and take it away.
So I'll be taking us back 1,000 years. My paper was on the biological chemistry of Islamic medicine, which I argue is kind of an antidote to our misconceptions about medieval psychiatrists in general. So, okay, there's a bit of issues here with the transfer, but that says psychiatry. So essentially, a lot of issues in psychiatry up to the modern era come in terms of defining its pathology and where it lies, whether in the brain, whether in the mental and whatnot, lie in the kind of classical mind-body problem, which I'm not going to go into in detail. But for those who know, Descartes essentially believed that there was such a thing as a mind or an immaterial soul that somehow surveyed and controlled the material body. This, into the 20th century, led to sort of issues in defining psychiatric illness as either, older physicians here definitely have heard this a lot, and even younger ones, but organic versus functional distinctions. So say someone presents with delirium, and we find out that, okay, the delirium is caused by an infectious process, organic, right? The delirium actually ends up to be a psychosis in a 21-year-old male without any kind of medical or chemical imbalance. We'll call it functional, meaning that it's not a sort of organic process. That's the language. So, you know, the way that we see the psychiatry nowadays is increasingly neuroscientific, which essentially posits that like mental illnesses are all organic, right? There's also difference. They're brain processes. They're processes that don't differentiate between these kind of mental and physical pathologies, but are all physical. So in contrast to this kind of neuroscientific worldview, we kind of stereotypically assume commonly that the Middle Ages was kind of this era of unscientific, supernaturalistic, and sort of mystical view of psychiatry, the mental patient, right? So we imagine like medievalists as running around burning people at the stake, and if they're crazy, then, you know, quote unquote, then, you know, get rid of them, imprison them, beat them because God has sort of forsaken them. So according to this view, of course, this takes a kind of mental or soul aspect in the equation. So, you know, according to this view, the medievalists didn't believe in a physical brain causing these issues, but nevertheless believed in a soul being afflicted by either sorcery, possession, or curses. And so in this sense, it's sort of categorically different than physical medicine. So this view of the Middle Ages is completely false. It's nothing but a stereotype. Medieval psychiatry, specifically the physician's aspect of it, was largely biological. And one key area in which this is very much the case is the Islamic medieval world, where those physicians essentially believed that psychiatric illness was a social, relational, or environmental, and even congenital disease that was located pathologically in the brain, exactly the brain. And their treatments consisted of early pharmacology, lifestyle changes as we do now, and psychotherapy, even early forms of it. Before getting into that, this was fun before, but anyways. I'll just talk about the stereotype for a bit. So it was a popular stereotype throughout the 20th century. First example is a book I actually found here by Zilborg, which is a popular kind of undergraduate psychology textbook that was used for decades in the 20th century, which essentially states that medieval psychiatry was based in occult practices, right? So demonic practices and sorcery and whatnot. Another example is an interesting little book I found by Robert H. Felix, somewhere here, who was president of the APA at some point, who actually wrote in his book Mental Illness, Progress and Prospects, that for as long as man can remember, there have been those of his fellows afflicted with demons and devils or punished by spirits, who cause behaviors to be considered deviation from the normal. And man has always been attributing to the supernatural that he cannot otherwise explain. Later he says that the spread of Christianity following the collapse of Greek and Roman civilizations closely paralleled this reversion to demonology that characterized the Dark Ages. So there's some truth to the stereotype, of course. Some people were unfortunately treated with derision and humiliation in the Middle Ages. The reason behind this discrimination was sometimes based on supernatural beliefs, such as sorcery and demonic possession. And so religious clerics and more members of the religious world would apply like their own treatments, such as exorcisms and whatnot to these people. That did exist. For example, here Shakespeare's another example in Macbeth. Whoever knows this section of Macbeth will appreciate. But essentially, there's a doctor of physics that comes in to visit Macbeth when she's gone completely cuckoo, and he assesses her basically, and his impression plan at the end is: foul whisperings are abroad, unnatural deeds do breed unnatural troubles, infected minds to their pillows will discharge their secrets, more needs she the divine than the physician, God forgive us all. Essentially, the doctor's like, listen, this is not a medical problem, this is God's problem, good luck. Madness is not my realm, it's not a natural realm, but an unnatural realm. But even if there's some truth to that stereotype, it's still just a stereotype. The mentally ill were not always treated badly. In fact, I basically learned that most of the time they were accepted in the community as long as they kind of respected social norms. And what I mean by that is the norms that we still kind of live by, right? Don't beat people up, don't yell, don't run around naked. If they did that, then indeed they were punished. But it wasn't necessarily because they were afflicted by curses, but because they were behaving in ways that socially were not acceptable. And contrary to Shakespeare's physician in the Macbeth, the medieval physicians were themselves by and large believers in physical and social etiologies of mental illness. In fact, more so than early 20th century psychologists who were influenced by psychiatrists who were influenced by Freud. They really saw it as a brain disorder. And they were oftentimes, in fact, asserting these beliefs, against religious institutions. So a quick background here. This too was fixed, but apologies for this. We thought it was fixed. So the medievalists, of course, were inspired by the Greco-classical tradition, in which the Hippocratic corpus sort of suggests, as many of us know, that explaining pathology in the organic body is a kind of balance between blood, yellow bile, black bile, and phlegm, and you have to have those balance to be sort of healthy. So Galen is a Greek physician who's on the image here, who essentially brought in the anatomy, who's the first kind of real anatomist. He brought in this notion that pathology and pathophysiology was found in the organ. And interestingly, he never quite wrote on mental illness specifically, but we see in his various notes, we can kind of make up a picture here that when he does discuss sorts of mental diseases, he indeed discusses them as diseases of the body and not of the soul. No such thing for him as the soul. He talks about the soul, but that doesn't cause illness. It's something spiritual to him. So this brings us to medieval Islam. So the physicians and the philosophers of medieval Islam, of what's essentially called historiographically the Islamic Golden Age, which was a period of enlightened thought in Islam that roughly spanned the European Dark Ages. They had sophisticated theories and treatments of mental illness. They were really sort of up there in terms of their investigations of the mentally ill patient. They didn't segregate themselves, as we did in Europe, as much between secular and religious. They sort of blended both theological and scientific theories into their practice. And their medical and scientific worldview was heavily inspired by the organic approach that Galen introduced, as well as other members of the Greco-classical tradition. I'll talk about three significant ones in terms of psychiatry, who basically introduced this kind of notion of like the organic psychiatric problem into the European medieval scholarship. So our first scholar and doctor here is Al-Razi, who's also known as Razes. He's a 9th, 10th century Persian physician and philosopher who is known for his approach to the kind of empirical investigation of disease and its treatment. He completely disavowed all religiosity in favor of empirical reason. So although he's Islamic and believed in his faith in Islam, his notion of like studying the psychiatric ill was completely divorced from religion. He has a collection of lecture notes called Kitab al-Hawi, in which he discusses various mental health problems. I selected the most important ones, one of them being melancholia, which we sort of equate to clinical depression nowadays, but isn't quite the same thing at all times. But for today, we'll just equate it for that. It's caused by burning black humor that ultimately reaches the brain and damages it. So black bile causing damage in the brain is now not really thought to be realistic, except nevertheless, he still saw it as an inflammation of the brain, which is quite interesting. Symptom presentation was sort of sorrow, sadness, fear, and irritation, hatred of others, isolation, and discontent with oneself, very similar to DSM-5 categories. His treatments were essentially to get rid of this bile in the brain. This could be by means of warm baths, pharmaceutical means, or interventions with plants and minerals. But what's really interesting about Al-Razi is that he introduced essentially behavioral and psychotherapeutic approaches, and he's perhaps the first psychotherapist ever recorded to actually put these practices down to paper. He would essentially do what I would think is considered to be basically CBT without naming it CBT. So he'd go to these anxious, depressed patients who are always ruminating and obsessively thinking about their life problems and not really getting anywhere. And he would say, listen, here's some ways to move on and not think this way, and that's CBT. The second one is a little less well known. I had to dig for this guy, but he was really interesting. His name is Ibn Imran. I'm not, for other Arabic speakers, I apologize. He was a 10th century Iraqi physician who worked in Tunisia. He's the guy the scholar who published the first ever monograph solely dedicated to melancholia. He also discussed what would be perhaps mania and bipolar. He introduced the hypothesis that melancholia could be inherited biologically from either malfunction of the uterus or sperm, according to him. He also believed that environmental causes such as eating badly or drinking too much or extreme weather conditions, cold or seasonal changes could make us melancholic. And so in this sense, what's key about him is that he introduced this notion of pathogenic duality, namely the fact that mental illness, as we believe nowadays, emerges from either or genetic predisposition plus environmental factors that might influence it. So it's not both or either. It can either be both or each. This was his monograph on melancholia was used throughout Europe for centuries following this, and perhaps an early form of genetic thought towards genetic predisposition of depression. So Ibn Sina, who's known as Avicenna in the West, he's perhaps the most important intellectual and scientific figure in all of medieval Islam, if not Islamic thought, prior to the 20th century. His most famous medical work is the Kanun fi Tibi, which is the canon of medicine, an extensive medical encyclopedia. He included significant portions to the study of mental illness. In this regard, he was inspired by Aristotle, who believed that the intellectual faculties were in the heart. He switched it up and said perhaps they're in the brain. And like his predecessors in the Islamic world, he was privileged in empiricism and rationality over supernatural explanations. He developed a very mature theory of knowledge, which mimics a bit what Immanuel Kant brought in Europe about 600 years later. But essentially, this is kind of a convoluted quote. He says, data of sense perception are filtered through reason to ascertain their conformity to existing theories that are held to be true. Okay, what does that mean? It essentially means we feel things, we see things, we hear things through our senses. They come into our brains or minds, we think. We use reason to kind of test whether this knowledge is true, and then we reapply it to the world. So early scientific empiricism, essentially. And so this kind of inspired the way that he separated mental illness into two categories of diagnosis. First, being in relation to the internal faculties of reason. Second, in relation to like peripheral sensation. So for example, a classic example that he mentions is if a patient comes in claiming that they're hallucinating, but their eyesight is perfectly fine, they're not blind, they don't have whatever issue, they're not hemiplegic or anything, he would conclude that they probably have an internal cognitive problem, given that their vision itself is okay, but they're seeing things that aren't there. So he distinguished between central and peripheral, as we do now, but there was no way in which a central disease was considered, neurological versus psychiatric, or organic versus functional. So these diseases were separated between internal and external, peripheral and central, but not between like a mental or mind disorder, psychiatric disorder, and a body disorder per se. He also kind of studies melancholia, which he says is also caused by inflammation by black bile in the brain, and his treatments include lifestyle habits, running, jogging, hunting, whatever, and certain remedies. He also discusses phrenitis, which I would say is a close kind of correlate to delirium. He says this is caused as well by inflammation of the brain, presenting in lethargy, apathy, and delirium. This, he said, was treated by adjusting the body's moisture and temperature. So, in summary, these physicians of the Islamic Golden Era considered mental illness to be a legitimate medical process akin to the sickness of the body. Psychological and behavioral processes derived from malfunctions of the physical brain and not by these metaphysical afflictions of the soul or the mind. And this is important because in the kind of history of psychiatry and medicine, we don't go from, in Europe, like we used to think, we go from Greco-classical to Dark Age, where everyone is kind of hyper-religious and non-scientific, into the Renaissance and Enlightenment when we pick that up again. It's not true. The Islamic philosophers, in that sense, are part of our historical trajectory. They were inspired by the Greco-classical tradition, and they then inspired the medieval physicians after them to practice in an organic and scientific way. The complexity of mental sickness therefore required a multifaceted approach. So this included lifestyle changes, behavioral adaptations, early pharma, and early forms of psychotherapy even. So like 20th century psychiatry, psychiatric and behavioral issues emerged from a multifactorial composite of elements. These could be biological dysfunction of the brain, genetic predisposition, or environmental causes. So essentially Islamic psychiatry had very similar ideological kind of notions as 21st century psychiatry, as well as a very brain and organically grounded approach, making it quite similar to us. And so therefore, I conclude, again, that medieval understandings of mental illness were not dogmatically anti-scientific or supernaturalistic, given that they were inspired by these philosophers and physicians. Now, why does this matter? One, because its history is fun and cool, and it should matter. Two, because the progress of scientific discovery is founded on fundamental worldviews. So it's important to recognize that science comes out of an experience, but the way that we do our science and the way that we sort of ground our theories of science before even doing the experiment will actually dictate a lot of what the conclusions we get from them. So historically speaking, we've been doing organically based psychiatry for a long time. We had a bit of a relapse in the 20th century, but that wasn't kind of like, the history of psychiatry and medicine isn't just kind of this like uphill battle against forces that are opposed to science, but have always been, the scientific approach has always been there, and there's always been those forces present, such as powerful religious institutions in the past. And then I think the key point here, that it might be a stretch, but I think it applies, is that psychiatric patients, we believe they kind of used to be tortured and treated horribly in the Middle Ages. It's not entirely true, but they still do suffer discrimination in every part of the world. The basis of this discrimination seems to be this kind of unquestioned bias that we have, that the mentally ill suffer in a way that's not the same as the physically ill, right? So if someone has mania or depression or anxiety, they're suffering, but then it's not like having cancer. It's not like having arthritis. The pain that someone goes through and the way they act when they have an anxious disorder could be socially unacceptable, right? So sweating or, talking rapidly, or other disorders such as autism spectrum. And the reason we kind of, the unquestioned bias here is that their minds and who they are is kind of sick, and that's partly their fault, and not their bodies. That's not their fault, right? If you have cancer, well, that's depressing, and you're a victim of unjust circumstances. If you have a mental disorder, it's still sometimes seen as someone not being necessarily being a victim, but also being a perpetrator of socially unacceptable behaviors. I think that once we recognize that psychiatry and psychiatric illness is grounded, we all accept that it's grounded in either the brain or the environment, and a mix of both, we'll stop sort of seeing psychiatric patients as sort of different than the physical patient, but equally victims of illness. And Islamic psychiatrists knew this 1,000 years ago. So you have to do better.
Thank you, Emmanuel.
Sorry,
Do we
questions?
have any questions?
Thank you for a very broad historic overview, and also for suggesting that the 20th century was a long time ago, kind of reassuring to some of us. Now, you suggest many things, and they're all interesting. Two of them are that we need to declare and accept the notion that psychiatric illness are organic brain problems, right? Processes of some kind. Is that yes or no? I'm not pushing
in some
you,
kind,
I'm just
yes.
trying to understand.
In some kind, yes.
Sorry?
In some ways, yes.
Okay, that's fair. So where's the hesitation?
Because the processes linked to the neural processes occur in the brain that may lead to depression, to mental illness. But I also do think that there's other kind of non-brain aspects to mental health and whatnot that can contribute to. But yeah.
Thank you. That's actually quite good, because Thomas Insel, who, when he retired as head of the National Institute of Mental Health, wrote a book declaring that we will soon understand psychiatric illness through genetics and biochemistry.
Sure.
But he was a patient guy, and 10 years later, he wrote a book saying I was wrong.
Yeah.
So he also hesitated. So
Yeah.
you're in good company.
Do we have time for one more? Yeah?
Just wondering how you see the autism sort of spectrum in this sort of psychiatry sort of concept.
So I think autism spectrum in terms of the psychiatric presentation, and the reason why we tend to refer people suffering, or who don't suffer, but who have autism spectrum to psychiatrists, is when exactly their behaviors become socially unacceptable, so agitation or repeated jerking movements and whatnot, and that's when it enters psychiatry. So it's neurology when it is socially acceptable, and psychiatry when it becomes socially unacceptable, which is a strange and unhealthy demarcation, I believe.
I think that's all we have time for. So I thank the audience for their very inspiring questions, and thank you to the 3 essay finalists for superb presentations. I know I learned a lot, and I hope the audience did as well. And I wish you all most luck in your future assessments, essay evaluations, and such. I don't want to be a judge right now because I'm sure it's very difficult to pick a winner. So moving on, I would now like to invite Dr. Chris Feynman, son of Dr. William Feynman, who is a cardiac surgeon who is joining us today from Toronto, to talk about, to give a few words and award our 3 essay finalists with something very precious and special. So the floor is yours.
Well, thank you. My dad, William Findell, as many of you probably know, was a very staunch Oslerian. He worked with Wilder Penfield, and he was the director of the Montreal Neuro, and I know Rolly knew him very well, and I think he inspired you, at least according to you, which is nice to hear. He inspired me. I was originally an engineer, but eventually went back to medicine because my mother, who was a neurosurgical scrub nurse, said do anything but medicine, having lived, knowing how tough a life it was. So Dad had a strong interest in the history of medicine, and he was very focused on Sir Thomas Willis, which, as you know, who described the Circle of Willis. But Thomas Willis in 1665 published the anatomy of the brain and nervous system. And Dad was fascinated by this publication. It was very advanced at the time. Willis was surrounded by individuals such as Christopher Wren, Boyle, and Locke, and a group of them formed the Royal Society in England. Very advanced group of thinkers for the time. So a 300-year anniversary, Dad spent a lot of time putting together the 300th sort of facsimile edition of the Thomas Willis's book, The Anatomy of the Brains and Nerves. And you'll see, so each student is going to receive one of these. When Dad died, he had a number of volumes left over, and the Osler Library very kindly accepted them. And we thought, I can't think of anything more pleasing to Dad to know that you students will get one of these, and please enjoy it. So I'll give the first three out, I think. Rolly, is that? So, Amina? So there you go. You can pick any one. They're all the same. That's for you. And Megan? Where's Megan? There you go, Megan. And Emmanuel. And just to finally end off, Dad was the president of the Osler Society in 1945, and I was in 1973 or 4, I think. So I don't know how many father-sons have been president of the Osler Society. Anyway, thanks very much.
Thank you. Now we'll move on to the second part of the evening. So since we want to maximize your exposure, oops, I'm not going to steal the show yet. So since we want to maximize your exposure to the variety of subjects and also offer our wonderful Molina scholars their well-deserved recognition, the Molina Scholarship Award winners will now be giving us a brief glimpse into their essays. So following the end of each presentation, like we've seen for the last session, we will move on to a brief question period, and I also invite the audience joining us online to, again, send in your questions. But before we begin with our presenters, I would like to thank Dr. Mario Molina for his generosity in making this evening possible and awarding our recipients with this scholarship. Dr. Molina, just a few words about him, is an esteemed leader in medicine and business. He previously served as the chairman and CEO of Molina Healthcare to provide healthcare to low-income individuals receiving benefits through government programs such as Medicaid and Medicare. He was featured in Time magazine as one of the 25 most influential Hispanics in America. He's a trustee of Johns Hopkins Medicine and served on the visiting committee for Harvard Medical School and for Harvard Dental School. So, Dr. Molina, I invite you to the floor to say a few words.
Thank you. So, when I was a first-year medical student, I had the opportunity to do a research project in my first and second years of medical school. And I worked in insulin secretion, worked in a laboratory, and the doctor that I worked for became my mentor. He helped me in my medical career, and he also encouraged me in my interest in the history of medicine. I wanted to provide these opportunities to the medical students here at McGill so that they could have a similar experience and do some research on their own. The great thing about McGill is that for people interested in history or humanities, you don't need a laboratory because the library is your laboratory. And McGill has one of the finest medical libraries in the world. But more than that, it has two other things that are very important for a program like this. One, it has students that want to do this work. And the second, it has people like Mary Hague-Url and the faculty here who are willing to give their time to mentor the students. So I think that McGill is the perfect place to have a program like this to encourage students to do research in the history of medicine. Thank you.
So our first presenter will be Paris. Paris is a second-year medical student, and prior to pursuing medicine, Paris actually studied engineering and worked in the field for 12 years. Her journey to medicine was inspired by a personal experience that deeply impacted her and motivated her to make this transition to medicine. Beyond her academic pursuits, Paris is a busy mom to a 4-year-old and enjoys planning travels and outdoor activities with her family. So Paris, I welcome you.
Thank you for the intro. Hi, everyone. I'm very excited to share my summer research on restoring Avicenna's tomb, a historical analysis of William Osler's efforts. So on the left side of this slide, you see a picture of Avicenna's tomb when Osler saw it about 100 years ago. On the right side, you see a picture of the tomb that Osler never saw. But in a sense, it was what his dream was. So in the short time that we have together today, I'm going to share with you a very fascinating story. I'm going to share with you first Osler's deep interest in Avicenna and collecting manuscripts, how he merged that interest into his vision for the medical profession and wanting to honor this fatherly figure of Avicenna and bringing solidarity within the medical profession of the time. And I'll highlight to you how strategically he planned for all the communications and strategically planned ahead so that he can raise the funds that he needs in order to restore the tomb of Avicenna. Last but not least, I want to tell you about a man who is less known to any of you. His name is Dr. Said, and he was from Iran. He's basically the moving piece of this puzzle because he was the man behind most of the Arabic manuscripts that Osler collected, and he's also the man who engaged Osler in restoring Avicenna's tomb. I'll be speaking as fast as I can. This story is so fascinating. There are so many details and so many pieces to it. So I'll really touch base on just overall pictures of the story, but I'll be happy to answer questions at the end. So Avicenna was a Persian physician. Thank you to Emmanuel. He already gave an intro on this, so I'll go very quick on this. So he lived around 1,000 years ago, and his life story is very interesting. We won't get into that, but basically he served as a physician to kings and princes, and he authored a lot of books at the time of his living, and one of the most famous is the Canon of Medicine, or the Rule of Medicine. He died and was buried in Hamadan. Hamadan is a city in the north of Iran. And for those of you that are interested in archaeology, it's interesting to know that it was built on the ancient city of Ecbatana, which is an ancient city in the Persian dynasties from Median all the way to Achaemenid to Sassanid. So in a series of lectures at Yale in 1913, Osler made various remarks about Avicenna. For example, he referenced him as the author of the most famous medical textbook ever written. He's referencing the book Canon. Canon was the standard medical book in the 17th century in Europe and in the Arab world in all the medical schools. And Osler, in his words, describes that the story of Avicenna's dominion over the schools in the Middle Ages is one of the most striking in our history. He also acknowledges Avicenna's philosophical work, because Avicenna, besides being a physician, was a philosopher. And he says, "The touch of the man never reached me until I read some of his mystical and philosophical writing translated by Mehran." Here he's referring to the book Traite mystique by Mehran. So the exact point of how and when he got so interested in Avicenna is not really clear, but as we were researching, we speculate that it had something to do with his trip to Egypt in 1911. It was the first time that he travels to a place that is so far from his hometown in Ontario, and it's so culturally distant. And he's so impressed and impacted by this trip, and you can see that from the letters that he wrote to his wife during this trip, that he was just so amazed and impacted by the civilization and the culture of that region of the world, that it seems that right after that he got so interested in collecting Arabic manuscripts, because before that he had some Avicenna copies in Latin, but it seems that right after this trip he got so interested in wanting to know more about Avicenna and collecting manuscripts. So in pursuit of that, his deep interest in Avicenna, and we know he loves collecting books, he starts looking around to find Arabic manuscripts of Avicenna. And he happens to talk to his friend, Dr. Garrett, who was his colleague and who happens to succeed him as the Regius Professor at Oxford after Osler. And Dr. Garrett happens to have had a student who is now practicing medicine in Iran, at the British legation as the physician to the British Embassy, British legation in Iran. So he reaches us to the student and says, "Could you please help Dr. Osler?" So on February 25th, 1912, Nelligan initiates his first letter to Osler, and he basically tells to him that I heard from my teacher, Dr. Garrett, that you're looking for manuscripts. I do have some connections in Iran, and I'm going to get help from them, and I'll be in touch. We don't have a surviving letter of what Osler responds, but 2 months later, there is another letter from Nelligan again, where it's accompanied by a beautiful copy of Kanun, which is actually at the display in the library for those who are interested to go and see it. And basically in the letter, Nelligan makes a reference that one of my native Persian friends bought this for you, and basically he sends that to Osler. And I just want to make a reference that this is the first Avicenna copy that he collects in Arabic, Osler. So who is Nelligan referencing in his letter as his native Persian friend? So this entire research honestly could have been about this guy. He has the most fascinating life story. And I'll just say briefly that he was born in 1863 in a cleric Muslim family, extremely religious. At the age of 19, he has a lot of contacts with the missionaries in Iran, and at the age of 19, he decides to convert to Christianity. So you can only imagine conversion in Islam is forbidden, and it's a sin. So you can be sentenced to death. So this conversion brings a lot of tragic events to him and his family. So he's forced to flee his city, and he ends up going to Hamadan, and he basically takes refuge at the American missionary, and he works there for 10 years as a physician assistant. And this is where he gets his first exposure to medicine. After 10 years, he decides to travel to Sweden, first as a missionary, and then through a series of very fortunate events, meeting the right people that it just won't fit into the time of this presentation, he ends up going to London and studying medicine academically, and then comes back to Iran in 1895, and then for the rest of his life, he's practicing medicine in Iran until he retires. One of the interesting things, there is a biography of him, and we have a copy at the library if anyone is interested. It truly feels like a fiction. So if you're interested in reading his life story, it's written by his nephew. So it's truly a fascinating story to read. So after sending Osler his first copy through Nelligan, Said keeps looking for other copies for him. So one day he's at a patient's home, and according to Said, this patient has a vast library of medical books, and he notices a copy of one of Avicenna's manuscripts in there, which is a copy that is a philosophical work, looks at physics, logics, metaphysics. And then that day, instead of asking for money from the patient, he asked if he could have this book. And then he sends that as a gift. The book is actually here for the display. You guys can look at that. It's called Canache Illusions by Avicenna, and it's kind of looking at like metaphysics, like logics, physics, like the Sufism, which is a sect of Islam, and basically, he writes a letter to Osler, and this is the first time that these two men, for the first time, correspond together directly. Osler obviously is very happy. He's getting this beautiful manuscript, and he writes back to him, and this would be the beginning of a very profound relationship and friendship that these two men built together. So a few months after that, Said happens to be traveling to London, and while in London, Osler invites him to his home, and this is how the two meet for the first time. So Cushing actually makes a reference to Said's visit to Osler's main residence and writes, and among other pilgrims to 13 Norham Gardens who appeared at this time was a foreign-looking physician, Dr. M. Said, who bore under his arm an illuminated manuscript of Avicenna wrapped in a Persian shawl, almost as old, together with two other books, without which, as he said, he never moved, his Bible and Osler's practice of medicine. So here you can see actually a page of the Bible that Said carried with him. He was very religious all his life. And then the beautiful manuscript that he brought to Osler from Iran on this trip is also at display at the library for those who are interested to go and see. So while in London, Said and Osler actually connected very much on a personal level. They would meet so many times at the Bodleian Library and also at Osler's home. Not only they discuss manuscript, they discuss everything about life. The two of them have actually a lot in common. Most of you would know that Osler actually had a background in missionary. His parents were missionary himself. He actually started his education. He wanted to become a minister and a priest, and then he switched to medicine. So he kind of saw so much in common with Said. Said had a religious background. He started his life as a missionary, and then he switched to medicine. So for Osler, this was like, he saw an image of himself in Said, and because of that, they really built like a very profound relationship. And it was really during this time that the two really connected, and they started talking about the idea of restoring Avicenna's tomb. And it all started with Said describing the condition of the tomb to Osler, and this is how he describes it. He described it as a site in ruins used as a place for opium indulgence and drug consumption, because that's really what it had become at that time. So Osler, recognizing that this state was not deserving of Avicenna, he felt a sense of responsibility that he needs to do something about it. But beyond that, he also saw an opportunity here, because for him, unifying the medical profession was a goal. And this is something that he always worked towards. And because of this, he aimed to create a shared sense of belonging among medical professions to honor a fatherly figure like Avicenna. So to do so, he put a strategy in place. His strategy has three parts to it, and I will briefly describe it, and then as I go through the presentation, I'll just give examples, because the extent of the correspondences and the letters and the press releases, all of that is so extent that it won't fit in the time of this presentation, but I'll just give brief overviews. So here's a strategy. First, he wants to make sure that the financial consideration and how much this costs, is this something that is feasible? Osler is a very practical person. He doesn't want to take on something that he cannot accomplish. So first he wants to make sure, is this within something is this a fund that I can actually raise? Number two, he establishes a trusted committee. We all know Osler was the greatest networker. Me reading through all these letters, I was just so amazed at an era that social media didn't exist. This guy had his own social media network. He knows people, and then he knows how to talk to the people he doesn't know by bringing and mentioning the people he knows. So he was truly amazing at connecting with people. So he really establishes trusting committee. I'll go into more details of how his network goes through different countries. Like he goes all the way to make sure he has a really vast network to support this idea. And then press releases and media coverage. He made sure that before launching the fundraising, he's actually preparing the audience. He's doing all these press releases, talking about Avicenna, talking about the tomb, so that when he comes with that idea of wanting to raise the fund, then he already has all of those support. So I talked about financial consideration. So he reaches out to Dr. Funk. He was a medical missionary in Hamadan. And he reaches out specifically to this guy because this guy, just a few years ago, he had built a hospital in Iran, in Hamadan. So he knew very well what were the costs of building. He had also made a lot of connections in terms of building with contractors. So he writes to this guy, first asks him for support for this project, and then secondly asks him to estimate for him how much something like this would cost. So he receives a positive response from Dr. Funk, and they estimate the cost to be around £600 at the time. And so Osler thinks that this money is within the range of what he can actually raise. So he decides to, you know what, I am going to go with this project. So as a next step, he starts building a trusting committee. So on this page, you only see some of the individuals that he engaged in the project and to launch with the campaign. So also really believe in collaborative approaches. And one thing we know about him is that, like I said, he knows so many people. So when you look at the people that he's throwing to bring to this committee, you see that he's really reeling in influential people that can bring something to the project. For example, he's bringing people that are in leadership positions, such as president of Royal Society of Medicine, dean of various medical schools. He's engaging people in different countries. He's really influential people that are teaching Arabic and Persian at Oxford. So he's engaging people from different parts of the world, and he does that in such how he does it, it's such an art because he's leveraging the people he knows, and he writes a letter to someone he doesn't know, and then he basically uses his network and his own influence to make a difference and makes this project happen. And I find that extremely, extremely impressive for someone living 100 years ago. He's also, I just want to say that he's also demonstrating a lot of inclusion and cultural sensitivity because he's reaching out to people in different countries. He's not just saying, okay, you know what, all the money is in England and in France, so let me just go talk to these people. He's really reaching out to everyone. He wants to make sure that everyone feels a part of this project. And even one of the most interesting one for me was that he understands that Said, because he's a religious convert and he's no longer a Muslim, he is not as accepted as a native in that society, in that Islamic society in Iran. So he even brings to the table for them to engage a native Muslim Iranian as a committee to just make sure that this project is going to be as accepted in that society as a project from within, that has people from within Iran part of. And the most fascinating of all of this is that he's orchestrating all of this from his office with a pen and a paper. Just realizing that how he's doing this over 100 years ago. It's not like today, emails, one press of a button and you're sending. He is making so much effort, sending so many letters to this people, to that person, and it just gives you a notion of the amount of effort that he was putting into this campaign. I mentioned that as part of the strategy, he also coordinated with his committee to publish articles on Avicenna. These are just some of them. This was all in preparation to going live because he wanted to make sure that once he goes live with wanting to raise funds, everyone is mentally prepared. It's so funny because as I was doing this, I was just thinking, I come from the business world, and in the business world, you go to the best business schools, and they teach you about this technique, and it's actually it's a Japanese technique, and it has this name that I never remember. It's called namawashi, and it's basically what it does is that it tells you gain acceptance and pre-approval from stakeholders, so that when you actually come with the idea, you're minimizing resistance and you're increasing acceptance. And this is what this guy was doing 100 years ago without going to a business school. And it just shows you like he was truly like a true leader. And that's the approach that naturally came to him. So everything was well on track. Unfortunately, as they were going with the campaign, World War I happens. So despite the efforts of Osler, they would have to cancel the campaign and put it on hold for a while. He received a letter from Neligan in July 1914, basically informing him of the situation in Iran. And by August, the situation gets so much worse that they decide, okay, we need to postpone the campaign till after war. However, no one knew that war is going to take 4 years. Longer than Osler or anyone else thought. And there are no letters in the correspondences between 1914 and 1916. Actually, between these 2 years, Osler is so concerned about Said because usually they are in contact all the time, but during the war, it's very hard to keep in touch with Iran. And Said, at some point, he had to flee his hometown because his home was under attack by Ottomans because he was a Christian and his wife was also Armenian. So a lot of life events happened to him. So Said even writes to the British legation, like for them to try to find Said and like make sure that he's safe. But anyways, in 1916, he receives a letter from Said, which is very descriptive. It explains what has happened to him in the past 2 years, and it also gives a lot of references to the context of the international situation at the time and what was happening during the World War. This letter is actually digitized in the Osler library, and I think we do have a copy here for those that are interested. I find it a very, very interesting letter for those that are interested to read it. So despite all these difficult circumstances, as soon as the war is over in 1919, Osler is very determined to launch the campaign again. So he starts corresponding again with the people he knows and those who had engaged in the project, and he even started writing to new people because he wants to gain more support. At this point, he's actually very determined to reignite the restoration project because Osler, at this point after war, he's strongly opposing the idea of nationalism, particularly in the context of medicine. He's continuously expressing concern about the impact of war on the medical networks, and for him, there is no room, as he says, there is no room for chauvinism in medicine and how nationalism is a curse to humans. So at this point, his aim to restore Avicenna's tomb is no longer just to honor Avicenna. For him, this is much more geared towards bringing the profession together and unifying the post-war segregated medical profession. Unfortunately, despite his effort to relaunch the campaign, the situation in Iran is deemed not ideal. In a letter that is sent to him from Neligan in 1919, they say that the cost of building material has gone up and Said is not in favor of doing anything at present. Perhaps it would be best to wait until 1920 when I hope to see you again. Osler responds in a subsequent letter saying, all right, we better postpone the collection of any money for the repair of the tomb until 1920. Unfortunately, we all know what happens. By end of 1919, Osler's sudden death brought a lot of sadness to the medical profession and also to the and also the story of Avicenna tomb had to come to a sad ending. And shortly after his death, Osler, at the Lady Osler's request, Cushing begins gathering material for his biography. And it is through the Cushing's collection called Cushing Funds that we have access to the narrative I have shared with you today, as well as the letters and the events I was able to reference for you. I have to go just a bit quicker because we're running out of time, because I don't want to finish this presentation without telling you what the fate of the tomb became. 20 years after Osler's death in 1939, the Iranian Ministry of Education made an attempt to honor Avicenna and restore the tomb. However, again, World War II breaks, and then they have to put the project on hold. But as a third and final attempt, in May 1954, they finally built the stunning structure that you see in the picture. As a last remark for this presentation, I'd like to make a reference to the idea of unity and universality. Osler's commitment to preserving medical history and honoring the pioneers before him was always obvious in his action. His ultimate objective remained to act without prejudice and stay inclusive, and I felt that truly in every word of every letter he inked to paper that I had the privilege of reading through my research. My hope is that this narrative inspires others to act without prejudice, to transcend borders and ethnic boundaries, and to honor history, for we all owe so much of what we have today to those who came before us. Thank you. Sorry, I just want to make it, I wanted to go quick, so I just want to make a remark. Thank my supervisors, Dr. Wallace, Dr. Manoukian, and Dr. Yarl. And a special thank you to Dr. Molina for funding this research. Thank you.
Thank you, Paris, for so beautifully narrating this story. I think we have no time for questions? No time for questions. You can bother her after.
At the end. Thank you.
So now I would like to invite Nivya to come up here and give her presentation. Just a bit about Nivya. So she's a second-year medical student at McGill. Her research interests include artificial intelligence, epilepsy, neuroimaging, neuro-oncology, and neurosurgery. She's excited to be working on her project that she's going to present to you all today. So Nivya is a third-year medical student. I have her bio from last year, but she's a third-year medical student.
So hi everyone. With a lot of slides and little time, I'll dive right in. So my project is called The Central Nervous System in the 18th Century, Japanese Dissection Scrolls, Art of Observation and Dissection. So the objectives of my presentation were to outline the anatomical illustrations of the CNS in the Dutch translation of Comus's anatomical table book and correspond them to like the wood engravings of Kaitai Shinsho. Then I'll assess how this volume was used as a dissection guide to depict the CNS in these dissections. Then I'll outline how scrolls and manuscripts depict dissections may have been used to teach anatomical knowledge in Japan during the 18th and 19th century. So a bit of background, during the Edo period, so which marks from 1603 to 1867, Japan was under Tokugawa regime under a national seclusion policy because there was colonial expansion through Roman and Catholic missionaries, and they saw this as a threat. So they prohibited traveling, and foreign exchanges were limited to Chinese and Dutch merchants. So Sujita Jinpaku, who is the main person we'll be talking about today, was a court surgeon of the Obama clan, and he had received a Dutch edition of Comus's anatomical book during this period. And something to note was that Buddhism and Confucianism prohibited autopsies of dead bodies. So this resulted in Sino-Japanese medicine having the wrong ideas of medicine. So this is a quote by Sujita. So he believed the emergence of true clinical and medical science based on observation and experimentation, as well as the application of new diagnostic methods required scientific knowledge of the human body. And this is how we came into publishing Kaitai Shinsho. So I'm not separating my projects into the objectives, but rather I'm going to take you back into time. We're going to look at 1734 to begin with, and we'll go through it as a little story. So in 1722, the book by John Adam Comus was first published, and then this was translated into German in 1734. Then another important incident is the first dissection in Japan, which was in 1754. And during this time, dissections were not super popular, and it was very controversial. So another dissection we'll focus on is 1771, because this was the dissection that Sujita attended, and this is what gives rise to Kaitai Shinsho in 1774. We'll then also look at scrolls, the Osler manuscript, and the codex that are all in the Osler library. So to begin, we'll talk a bit about the Dutch volume. So who is John Adam Comus? So he was born in Breslau, which is in Poland today, and he attended university in Germany and Netherlands. He taught physics and medicine at Danzig. He was a Lutheran, so we see a lot of reference of Lutheranism in his work. So as I mentioned earlier, the first edition was in German in 1722. Then there are several editions, but our main focus is on the Dutch edition, which was in 1734. So I'm skipping the first dissection because the dissection we'll be focusing on is the one that Sujita went to, and this is in 1771. So on March 3, 1771, Sujita was invited to go to a dissection which was happening at a near site. So he invited two of his colleagues, and one person to note is Meino Ryutaku, who is a senior. And to his surprise, they both brought the same edition of the Dutch volume to the dissection site. And they both were very surprised by the differences in the Western illustrations and the Chinese treatise, which had the traditional descriptions. But they were also realizing that this book was very similar to the dissection that was taking place. So that is what sparked the light. And this is when they were returning from the dissection, they decided to start the translation of the Dutch book with their elementary Dutch knowledge. And after the first day, they were able to complete 10 lines. And okay, so just for a reference, this is the Chinese treatise at the time. So for time constraint, I'm going to skip over the first part, but you could see that it is very different than the human anatomy we know nowadays. And since I'm focusing on the brain, we will look at how here, you can't see my mouse. The brain basically fills the posterior cavity, and the forepart was empty. And there was also a misconception of the role of the brain. So they believed the heart was what controlled the body and the memories. And we could also see the medulla would begin at the neck, but it would go all the way down to the end of the spinal column. And please keep that picture in mind because I'll be referencing it as I go. And now we'll be discussing Kaitai Shinsho. So the dissection took place in 1771, and 3 years later is when this book was published. So this book is a Sino-Japanese translation of Comus's book, and Odano Notake was the illustrator of this book, and he transformed the copper plate illustrations into woodcuts. So it was completed in August 1773 and then published in 1774. So some general comparisons that were very obvious, I feel, were initially was the title page of the book. So on the far right is what we have as the Kaitai Shinsho's title page, but on the far left is what is the Dutch volume's title page. So this, you might ask, why was this the case? So it could have simply been that he liked the cover page of the other book more than the other one. But some issues that we encountered in his writings were there was an issue of censorship. So on the far left, you could see that it was a woman's body being dissected by a woman, and then there's another woman also holding up the curtain. But during this time, seeing a nude woman's body was not ideal and was not seen as a good thing, which is why he was concerned that this might not be published, and he decided to go with the other book's cover, which is called Vive Imagion Partium Corporis Humani. I might be not pronouncing it right. But some little things to notice are also, there's the Adam and Eve's reference in that book, and it was exactly copied, but we don't know if this was intentional. You could also see the apple that Adam is holding. But also here on the far right, you could see that their genitals were covered, which is not what we see in the middle. So this is the issue of censorship that they would have faced. Also another note is the footnotes. On your left, what you see in the middle, it basically says comments, and under it are like all the comments. So they would make a lot of references to the Achilles heel, King Solomon, and the circulation of blood, and very interesting stories and traditions, like they had pressing in India that they used to do to infants. But this was all omitted in the Kaitai Shinsho. But rather, we could see that there are margins left on both sides, and we think that it might have been for students to use this as a book to take notes either during dissections or when learning anatomy, similar to what we do nowadays. And while reading as well, I realized they noticed that there were different annotations by different people in different inks, and then they would sign their names at the end, which also shows us that these students would have used this book as their guide when learning anatomy. And now we'll go into comparing the central nervous system. So as you could see, both images are very similar. So we have the Dutch version on your left and Kaitai Shinsho on your right. Some interesting things to notice is the Circle of Willis. We were talking about it earlier. So we said the book was published in 1665, and the Kaitai Shinsho was published in 1774, but where is the Circle of Willis? Not there. So what we see is the brain was copied exactly from Kulmus's book. And another interesting thing to notice is on the left, there's a little defect in the brain where the brain is folded, but this was exactly copied onto Kaitai Shinsho, even though the dissection that they would have been seeing might have not had this defect. So now we'll go into looking at the scrolls, the manuscript, and the codex that we looked at the library. Okay. So first, we have two scrolls. So the first scroll we have is the dissection of Hiero, which is a dissection that took place in 1783. And I'll just play the video. Hopefully it works. Yes. So as you see, this is a decapitated criminal, and very interesting pictures as we go on. We also see the central nervous system eventually. So here's the brain, sutures, dura, and we see the base. Okay. And then I'll play another video, which is the same dissection, but this scroll is in Philadelphia, and I'll ask you to spot the difference if you can. So as you could see, this scroll here has like darker colors, and it's missing some of the pictures that we saw in the previous scroll. So we wonder if this scroll might have been done after our scroll at the Osler Library, or would it have been just simply a different artist? Another instance to notice is the head. We saw in the other scroll, it's not letting me pause at the correct moment on the other scroll, but basically here there's blood on the ears and the neck, but it was not seen on the other scroll that we have at the Osler Library, so which also makes us wonder, is this an addition after to make the drawing look more realistic? So this is just us looking through the images that we saw on the scroll, but more zoomed in. So on your left, you would see the brain, and then they describe it as on top of the meninges, which basically we see the dura, and then the cerebellum, and here we have the choroid plexus as well. And now we could see the base of the skull, and if you see the optic nerve, they call it the eye system. And beside it, we see the eyes as well. And these are just images of the spinal cord and the sacrum. So it just says like from the left, from the right. Okay. And this is the second scroll. So this was a scroll that was done under the supervision of physician Soteki Fuseya, who was a gynecologist. And it was the dissection of a 37-year-old female with pregnant twins. And it's a great scroll because it's the first demonstration of filtering action in the kidney. And I believe Dr. Brendan Ross, who was a previous Molina scholar, did his project on this scroll. But something to note on this scroll is that we don't really see a lot of the brain, but it might have been just simply because the person who dissected this body was a gynecologist and was not interested in the brain. Now we'll go into the Osler manuscript. So this is from 1800. And this manuscript is based on Kaitai Shinsho, but some additions that we saw are like the Asian appearance of the faces. So if we compare this with our previous drawing from Kaitai Shinsho, we could see that there are differences in the features. And they have also some traditional Chinese medicine incorporated. So in the fingers, each finger would stand for like fire, water, wood, earth, and metal. And this was just simply a video of me going through the book. A lot of writing, and we see that each organ is given a page versus initially in Kaitai Shinsho, we saw that 5 organs were on 1 page. Oh. Okay. So now we're looking at the brain, and now, as I mentioned, we could see that each organ would have 1 page, and you could still see on the left the little defect that I was talking about earlier of the brain being folded. So it is interesting to see that this was carried out even though that multiple dissections would have taken place from the time this book was released and onward. And these are some impressive pictures of the central nervous system. And on top, it talks about sutras, which means threads in Sanskrit. So it was very interesting to see that this was incorporated because it would probably mean nerves. And here as well, you could see that there is cervical, thoracic, lumbar, and sacral, and I counted each spinal cord and it corresponds to what we know today. And finally, the codex. It's from a dissection that took place in 1845. This was done by Keishu Kamada, and he had 5 assistant doctors, and there were 50 or more doctors and students who came to watch this dissection. So we saw that the first dissection was in 1751, and then the second dissection we talked about was in 1771. So during that time, we didn't see if more doctors or students attended, and I don't even think Sujita probably attended the first dissection because it was not anywhere in his books. So now we're seeing more people seeing the dissection as a learning opportunity and learning the anatomy. And so this depicts the dissection of a decapitated criminal. And I don't know if you noticed, but the second part was mostly osteology, and the primary part were more the organs. And this also had a lot of notes where physicians mentioned the similarity between Western and the pictures that they're seeing here. So these were the pictures of the brain in the codex. So it basically simply says the front view, the back view, and here it says the meeting of the bones, which is the sutures seen. So just simply wrapping it up and going through the timeline, we saw the Dutch volume, then we talked about the first dissection, and then the dissection in 1771, where this Dutch volume was brought to this dissection, and then that led to the publication of Kaitai Shinsho in 1774. And now I'm asking you if you remember the Chinese treatise that I talked about. So if you compare all of the works done after Kaitai Shinsho and compare it back to the Chinese treatise, you could clearly see how much of an impact Kaitai Shinsho had on the future works in Japan. And just reading through the books and seeing all the annotations, we could see that it was used as an academic tool for anatomical teaching. And I'm wrapping my presentation up with a message that I read from Sujita's preface. So I'll read it out loud. Anatomy is the essential discipline for external treatments and surgery. It is not possible to ignore it. Therefore, those who wish to make progress in medicine will never be able to succeed if they do not consider dissections as the groundwork. Concerning anatomical treatises, the most important is to read them by referring to the pages displaying the illustrations. Those who read this book should change their way of seeing or thinking. Therefore, those who are unable to change their way of seeing cannot enter this new house of knowledge. So this quote again emphasizes how this book was made for others to learn from. And a little message for me, cheesy, but as you go through your day, we're always learning, and this is your reminder to keep your eyes open, because him not liking Sujita not liking the Chinese treaties and looking out for what could be changed brought Kai Tai Shin Show. So you never know what you have. Thank you. Oh, lastly, I'd like to thank Dr. Mario Molina for giving me this opportunity, Dr. Rolando Del Maestro for being a great mentor and always helping me out when I was in distress for this project, and Dr. Earl for finding all the gems across the country and the world, I guess, because we had a lot of books that we had to collect for this project. Thank you.
Thank you, Nivea, for such a wonderful presentation. In the interest of time, I think we're going to skip through questions, right, Dr. Earl? Oh, we do have time for questions? Okay. Does anyone have a question for Nivea? Sure.
You mentioned that the Chinese tradition didn't approve of dissection. They still seem to have some sort of impression what was going on. Was that because they would use cadavers that were already killed or stuff like that?
I'm not 100% sure, but from what I've read, dissections were prohibited completely, so I'm not sure.
Great presentation, thank you, Nivea. You mentioned earlier that they didn't have access to cadavers, right? So what sort of concepts did they use to visualize the individual location of organs and how they relate to each other?
Again, I'm not completely sure, but it is something I think is worth looking into, because I was very fascinated by the Chinese treaties, because it is not what I think of the organs after going through medical school. So I will definitely look into that and I'll get back to you.
Thank you. So now we'll move on to our third and last, but definitely not least, presenter. We have Yoel. He is a third-year medical student here at McGill. He minored in classical studies in his undergraduate degree, and so he's pleased to have this opportunity to combine exploring history and the humanities. After presenting his project on Jewish physicians and the popes at the American Osler Conference in London, he's excited to be back doing more research into medicine in the Renaissance. So, the floor is yours.
All right, thank you, Saruchi, for that introduction. Last presentation on the mind. And hello to everyone. My name is Yoel, and I'm here to present a presentation I prepared with my mentor, Dr. Henry, titled An Army of the Illustrated Dead, where I'll be discussing the use of style in Vesalius' Skeleton and Musclemen in deposing Galen as the Emperor of Anatomy. Now, there's a lot to unpack in that title, so we're just going to start off with a discussion on Andreas Vesalius. So he was a physician and anatomist that lived in the 16th century, and this quotation by his mentor, Johann Gunther, gives us a good general overview of his character. So first, Vesalius was the son of the emperor's apothecary, highlighting how Vesalius came from a long line of pharmacists and physicians. Next, he was extraordinarily knowledgeable in medicine, having studied at the universities of Paris and Padua, and later becoming a professor at the University of Padua. And finally, he was renowned for his skill in dissection. This was what he was best known for throughout the Renaissance, and he was actually noted by his students to constantly be carrying around chalk so that during his anatomical dissections in the theater, he'd be able to draw out what they should be seeing. So this obsession with dissection resulted in him publishing his magnum opus, De Humani Corporis Fabrica Libri Septem, which in English translates to On the Fabric of the Human Body in 7 books. This was a massive work of anatomy that was published in 2 editions in 1543 and 1555. And as a quick aside, Sir William Osler was known to have owned, over the course of his career, 7 of the first editions and 2 of the second editions of the Fabrica, having donated them to his friends and to different universities. Now, this work consisted of over 700 pages of text and over 200 woodcuts, all of which were dealing with the anatomy of the human body. Now, there was a complex and many layers to the motivation of Vesalius in making the Fabrica. Some historians focus on how Vesalius wanted the Fabrica to be a reference work for physicians and artists. Others discuss how the Fabrica was a gift for King Charles V before Vesalius was promoted to his own emperor-physician. But for our purposes, we'll focus on how the Fabrica was a lengthy document that was criticizing Galen. Now, who's Galen? Well, I could also thank Manuel for going over that a bit. But basically, Claudius Galenus was a Greek physician that was working out of Rome in the 2nd century CE, and he was the predominant figure in medicine for over 1,500 years. He was the main source that people went to when they wanted to look up things for diagnostics, for diet, hygiene, antidotes, and more. But what we'll be discussing is, or what was even the concern for Vesalius, was Galen's 2 anatomical works on anatomical procedures and on the use of the parts. And Vesalius's problem with Galen could be summarized in this following quotation, where Vesalius explains how he read Galen's book many times before daring to perceive any mistake on Galen's parts. The mistakes that Vesalius refers to are discrepancies between what Galen describes in human anatomy and what Vesalius observed in his own observations. But when Vesalius went on to dissect animals, he found that all of Galen's descriptions corresponded with the anatomy of apes, whose anatomy is similar but subtly different to that of humans. So the text of the Fabrica is mainly associated with refuting a lot of Galen's points, but what we're going to do is discuss how the illustrations in the Fabrica also tie into this prospect, both in representing Galen's criticisms, or the errors of Galen, and in emphasizing the humanness of Vesalius's own dissections. So the remainder of the presentation will be divided into 3 parts. First, we'll talk about those concrete criticisms. Then we'll go into Vesalius's own representations of humanness. And time permitting, we'll finish off with the reception by Vesalius's audience. So let's start with the criticisms. Now, when we analyze Vesalius's work, we're going to focus on 2 specific figures that he's made. The first is one of his 3 skeleton figures, and the second is one of his 14 muscle figures. So let's just first briefly describe what we're seeing here. On the left is a skeleton that's seeming to be melancholic, hunched over a dead stump with his arms drawn up to his eyes and his knees drawn in. On the other hand, we have this proud, tall, muscular figure standing upright, his arm extended, stepping forwards to a scene overlooking a Venetian landscape, his curly hair falling over his head. These contrasting depictions are just 2 of Vesalius's masterful works, but he utilizes them in such ways that he emphasizes humanity and criticizes Galen at the same time. Now, we're actually going to skip over the techniques that Galen uses in the interest of time, even though I really like that slide, and we'll just quickly go over what the specific critiques Galen has are. So, for example, one of them is in the skeleton. Galen claims that the lower 2 thoracic vertebrae do not have transverse processes, which for those who aren't familiar with is this little guy right here, which Galen depicts on the skeleton right there. Similarly, he has another criticism of Galen's lack of understanding where the latissimus dorsi muscle attaches. But what this all boils down to is the fact that Vesalius is emphasizing how he's making human figures, he's dissecting human figures versus Galen's animal figures. And so to do that, he needs to emphasize the humanness of his dissections. So let's start by analyzing the figures. Now, we already mentioned how these show contrasting emotions. One of them is melancholic, one of them is proud and upright. And so if we look at the context of both of these figures with their companions, we'd see that a pattern actually emerges here. So let's consider the skeletons first, where we see them all in these poses of deliberation, contemplation, lamentation, all these very emotionally poignant poses that strike this introspective and reflective attitude of the viewer. In contrast, The muscle figures are much more physical. They're proud, they're tall, they're showing grace and elegance on the one hand, and other ones are showing a very substantial and physical manifestation of pain and suffering. This is a very material view of humanity compared to the introspective view of the skeletons. So this contrast between the two groups of figures is actually another technique in the Renaissance that we could talk about, known as contrapposto. This was a concept that emphasized the juxtaposition of opposites, and it could be summarized well in this quotation by Alberti, a Renaissance humanist, where he says that good artists should incorporate contrast in their works, some figures being turned towards the viewer, others away, some being high and some being low. And when we look at Vesalius's works, we see that he incorporated these very well, both with each figure individually striking a unique emotional chord with the viewer, but also, if we consider them as two separate groups, we could see that they represent different aspects of humanity that are inspired by two different artistic traditions. The skeletons come from the medieval concept of the memento mori, whereas the muscle figures come from more the physical obsession from classical antiquity. So let's tackle each of these in turn, starting with memento mori. This was an artistic tradition that started in the Middle Ages and continued on through the Renaissance, where a figure of death accompanied a living figure to remind individuals of their coming mortality. For example, we could see this here, where a figure of death, the skeleton, is placing a necklace on a countess preparing for her day. Images like this were reminders to people of their coming mortality and the inevitability of death. And sometimes this imagery could be more overt, such as in this fresco, where death comes as a reaper riding a skeletal horse, and he's shooting arrows at individuals of all social standings. In both of these cases, the figure of death is a reminder to the individual, to the audience, of their coming mortality and the need for them to reflect on their life and to conduct themselves in a manner of virtue, emphasizing the introspective view of humanity here. So we could actually compare and contrast this to Vesalius's figure, where we see one striking difference in that Vesalius's figure is lacking a living human subject. Instead, Vesalius has fused the living and the dead into one figure, having the skeleton engage in human behaviors itself. When we actually look at what the human behavior here is, we could see that it's in a pose of lamentation, which in the Renaissance is highly tied to humanity and to Christianity, as evidenced by the following painting by Botticelli, The Lamentation over the Dead Christ. Here, we could see multiple figures engaged in much the same behavior as Vesalius' skeleton, hunched over the body of Christ, their hands run up to their eyes in lamentation. To the viewer in the Renaissance, what could have been more human than lamentation? By depicting his skeleton in this way, Vesalius was tying the skeleton into humanity and demonstrating that there was an inherent humanity within his figures, something that Galen could not do. Now, we could also look at the inspiration behind the muscle figures in classical humanity. It's well known in the Renaissance that there was a big movement to emulate the ancients, which was in no small part due to the rediscovery of a lot of statues throughout the Renaissance from classical antiquity. For example, the following statue of Laocoon and his sons was rediscovered in 1506, and it was admired for its striking depiction of pain and for the artist's knowledge in human anatomy. And if we want to find works that actually are inspired by these kinds of figures, we need to look no further than Michelangelo's work on the Sistine Chapel. Here, we could see his Last Judgment, where all of these Christian characters are represented as these highly muscled figures, hearkening back to those heroic depictions of characters from classical antiquity. Now, this too relates to Vesalius's work, where again, just like Michelangelo's figures, we could see these highly muscled bodies in his muscle men. If we want to relate this to a specific work from classical antiquity, we could consider that it may have been inspired by the Apollo Belvedere, which was rediscovered sometime in the 1490s. There are quite a few parallels between the Apollo and Vesalius's muscle man. We can see that the pose is very similar, the outstretched hand with the leg stepping forward. They both have curly hair falling over their heads. And even the drape that's garmented, or the garment that's draped over the Apollo, is kind of reflected in the muscles peeling back from the hand of the muscle man. So we could see that all of this kind of comes together to emphasize this very physical and lively aspect of humans. It's representing the idealized male form that was present in the Renaissance. So on the one hand, we have the skeletons representing this introspective view of humans, and the muscle men representing this very physical, ideal view of the human form, which comes together itself to emphasize Vesalius's usurping, so to speak, of Galen. But we need to consider that these aren't the only things depicted in the figures, since there were also some symbols there. So let's start again with these skeletons, which utilize the objects known as vanitas in the Renaissance. This was an emerging art form where certain symbolic objects would be included in artworks by artists to, again, represent the coming mortality and death. These were objects like wilted flowers, hourglasses, skulls, and more. And so if we consider Vesalius's skeleton, we could see that there at his feet, there is a tree that's been cut down and is dying. And so it itself is this representation of vanitas. It is a reminder to the viewer of their coming mortality, just like the lamenting skeleton is. All of that coming together to be an emphasis on the humanity of the subject. Similarly, the muscle man has a special surrounding him, a special little context surrounding him in the form of its landscape. And so we could see that landscapes as well were a large movement in Venetian and Italian art at the time. The difference here, if we look at them, is that Vesalius's figure is much more monumental within this Venetian landscape compared to the diminutive figures in Campagnola's and Titian's works that are pictured here. And this is further emphasizing that usurping of from Vesalius of Galen. Here, Vesalius takes a figure from classical antiquity, depicts it with his own dissected anatomy on it, and places it within the context of his time and place, emphasizing how he is the one that has made this human dissection and not Galen. Now, to highlight just how much this humanity plays a role, and depicting this humanity plays a role in Vesalius's work, I wanted to compare it to his earlier works. These are 3 images from the Tabulae Anatomicae Sex, 6 anatomical tables that Vesalius published 7 years before the Fabrica. And so we could see that they're still using artistic techniques to depict a skeleton. It's probably using some vanitas in the lower right corner there, same way with the other skeletons, but they're really lacking humanity. They're not posed in the dynamic way that Vesalius depicted the other skeletons. They're much more static in their poses. And so it's this kind of lacking of humanity that doesn't really give you a sense of inner liveliness or humanness to his pieces, just emphasizing how much that dynamism in his other figures puts the work in. So, to finish it off quickly, I want to take a look at the reception of the audience of Vesalius. And so this we could do, luckily, because there's been research going on just a few years ago where some researchers actually looked through every surviving copy of the Fabrica, which is about 700 of them, just so you have an idea, and they looked at any annotations that were left behind in them. Now, the annotations tended to be more in the text of the Fabrica than in the figures, but we do have some idea of what people thought of the muscle and skeleton figures that Vesalius made. So first, let's take a look at the annotations left on the skeleton figures, and we'll see that many of them had to do with the idea of mortality again. They say things like, everything is laughter and nothing and only dust will remain. Death is the medicine of pain. Our only security is to serve God, everything else is vanity. And death robbed him of all his beauty. So this is just showing that as much as we were speculating about what the meaning behind these figures could be, they're the same ideas that we just discussed, which the audience was feeling themselves. They had these emotional connections and resonations with Vesalius's figures. Now, I'd love to also show you the annotations on the muscle figures, but unfortunately they couldn't decipher all of them. The only one that was left behind was a reference to Pollux, who was a figure in classical mythology. But again, this is just showing mythology was on the minds of the people viewing these muscle figures. So, just to conclude, these works were admirable works of art in their own right, but overall, they highlighted these contrasting interpretations of humanness that helped Vesalius emphasize his own dissections of human bodies as opposed to the apes that Galen had dissected. So I'd like to thank everyone listed on this slide. I'd go through them, but I think I'm a little over time. And I hope after, especially these last 2 presentations, you enjoyed seeing some spooky images on Halloween.
You have time for questions.
All right.
So does anyone have any questions for Wael?
how much of these representations do you think were Vesalius, and how much do you think were the artist Stefan van Kalkar?
Yeah, that's a good question. So yeah, I didn't go into that in the presentation for time reasons, but yeah, so Vesalius isn't the one that actually made the illustrations, these woodcuts. It was Van Kalkar. But from what I saw in the research, Vesalius was heavily involved in every aspect of making the Fabrica, right? He's the one that, he did the dissections and all that, but he was kind of the director of how he wanted the poses to be made, what kind of, what printer they would use, right, where it would be sent for publishing. He was really on top of every single aspect of its creation. So researchers these days do agree that the poses that the figures are in came straight from Vesalius to the artist to make.
Very informative. So you mentioned artists had a very good understanding of anatomy and they dissected things in the Renaissance. What were their understanding of mythology? Because you mentioned Apollo, and I'm curious if they also studied mythology to make their artistic depictions of things.
If artists study mythology?
Yes.
I think I am not qualified to answer that question, unfortunately. I think that's a little too far from where my research was focusing. I think from what I know of the Renaissance, I think mythology was fairly well known by people who were learned. And so I think those high status artists would have been no exception, but how much that played into them creating their art, I'm not entirely certain. All right, thank you very much.
Thank you so much to all our amazing Molina scholars. If I can share something about tonight, I'm surely very impressed and quite frankly humbled by how much work and dedication, passion that each of you have put in to your presentations, and it just shows in the way you talk about it and the way you present it. So thank you very much. Once again, I would like to introduce Dr. Findell to present the very interesting, and I want one of those books, to our second set of presenters for this evening. So.
I think, as I said before, my father would be absolutely thrilled to be here. One thing he did is he took a lot of notes anytime he went to a lecture, and he'd always ask every presenter a few questions. One question. I failed to reach that threshold today, but I really enjoyed this. So please come up, the last three speakers. And Paris. I'm glad to see another engineer. And oh, there she is. Yeah. Congratulations. Thank you.
Now we will have Dr. Milton Roxanas give us a short presentation that I'm looking forward to. So just a little bit about Dr. Roxanas. Was actually introduced to William Osler as a medical student in 1964, and after obtaining his medical degree at the University of New South Wales, he embarked in psychiatry and obtained his qualification in 1974. In 2013, Dr. Roxanas was voted into the American Osler Society and has presented several times at the annual conference. His clinical work in psychiatry is primarily in the field of consultation liaison and neuropsychiatry, and he was formally appointed the Associate Professor of Psychiatry at the University of Sydney, but retired several years ago, so we're happy to have him today.
Do I need a microphone or can I speak? I need a microphone. All right, I'll need a microphone. First of all, I'd like to echo the words of Dr. Mario Molina about the function, the beauty, the coalescence of the Osler Library in getting together so many people and stimulating us so much. When I'm in London, I usually walk in German Street. German spelled Jermyn Street. I go there for two reasons. One, because it's got the best menswear in the world. But secondly, it has an antiquarian shop. And sometimes I buy something, sometimes not, but on that year I went in, I looked around, and there was nothing to buy. So I go to the man managing the shop, who was the son of the older man whom I knew, and I said to him, I notice you don't have anything medical. And he said to me, well, we did have an item, but it stayed there for a long time, and it wasn't sold, so I took it inside. So I said to him, can you tell me what it was? And he said, it was a glass stethoscope. My brain blew. So I said to him, may I have a look at it, please? So he sent his lady in. He said, get the glass stethoscope, and she brought it out. I had a look at it, by which time I wasn't thinking, I was floating. And I said to him, how much? And he said something like, I've forgotten now, it's £850. Oh. I said, can you give me a better figure, give me a discount? And he said, and why should I? Just like this, and I mean it. I said, well, you've had it for a long time. It wasn't sold. I may be interested. Can you give me another figure? And he said, all right. He said, I'll give you 50 quid. I said, I'll buy it. So I bought it. After buying this, I searched all over the world and I bought another one. This is the second one. The first one you'll see next year when I bring it. And I wrote to galleries, museums, medical museums all over the world, Australia, England, Canada, America, Europe, and no one had heard of a glass stethoscope except one, the curator of the Museum of the Royal College of Physicians in London. So I wrote him a letter immediately in those days, and I said, may I please have a picture of your glass stethoscope because I've acquired one. He said, yes, provided you send me pictures of yours. So the two sets of pictures crossed the ether. And I have a picture of his, and it's an obstetric glass stethoscope. It's smaller, whereas the two of mine are much longer. How did monaural stethoscope develop? Well, in those days, they had a lot of TB. And Laennec was lecturing and demonstrating, and he had a big fat woman. And he couldn't hear the sounds very well, so he walked forwards like this, went to a man who had a sheet of notes, and took it, rolled it up, and went and listened to the lady's chest. And that's how it started. He said, why don't we use the principles of sound? Now, Laennec was a good wood turner, and he made stethoscopes roughly like this with a hollow right through, and he put it on the chest of the patient and on his ear and listened to the chest. Now, Laennec actually sold a stethoscope with every book of his which was in the market sold. So there must be plenty around the world, but I haven't seen any. So there was a lot of argument. Are the glass stethoscopes better or not? And some argued for, some argued against, but nevertheless, I managed to acquire 2, and as far as I know, there are only 3, and I happen to have 2. Now, why are they so long? They are so long because people in those days did not shower every day as we do. They were dirty, stinking. Secondly, it was embarrassing to put your ear on the lady's chest and on her breast to listen to the sounds of the heart and lungs. So they were made long like this. Can I have help? Please. And what they did is to put it in his ear and the other part on the chest and listen like this. Now, this stethoscope is a simple one. It's got clear lines. But the other one I have is beautifully sculptured, a lot thinner, and I suspect it was made in France, whereas I really don't know where this was made. And there you are. That's the history of them. Now, I want to tell you about another stethoscope. There are also the small ones. Now, in those days, the physician had two parts of the stethoscope. And he put them together into a flat piece, and they used to put them on their top hat. And they would walk into the room of the house of the patient, and then they would remove their hat, pull out the stethoscope, join it, and listen to the chest like this. Now, the monaural stethoscopes were not very popular in America, and because of Kamen, was it, who championed the binaural stethoscopes, but there you are. And it's interesting, Osler didn't have any in his collection. That's all I want to say. Thank you very much. Thank you. Oh, incidentally, if you want a copy of the history of the glass stethoscope, I have a copy of my publication on it, which Mary has done, and you can get a copy here.
Just want to take 1 minute, and the 1 minute I just want to take is that Milton and his wife Viv have come all the way from Australia for 2 reasons. One, to bring the stethoscope, and second, because he's a member of the board of curators of the Osler Library. And I have to thank him very much, because there's not a lot of people that would come all the way from Australia 2 years in a row to come to the Board of Curators meeting. So that just gives you an idea of how much Milton and his wife feel about the Osler Library and about the process of the Board of Curators. The second thing I want to mention is Dr. Molina has come all the way from California. And another individual here, and the other individual who was also here today and yesterday was another individual who came all the way from us California to join us too. So I have to say that the idea that these individuals can come from such long sort of areas away, brings you back to Iran, brings you back to the whole idea of how this is a sort of very unique place where people want to come here to really enjoy the presentations of all the students. So thank you very much, Milton, and thank you very much, Dr. Molina.
So to conclude this evening's program, just to echo Dr. Del Maestro's gratitude to everyone here, I'd just like to take a moment to say thank you to all the attendees for your participation and continued dedication for making this such a great event. Thank you to the staff. Thank you to the Board of Curators of the Osler Library of the History of Medicine for organizing this symposium. Thank you to Pam and Dr. Del Maestro for supporting this contest and making this possible as well. Thank you to our amazing presenters for delivering such pearls of knowledge, allowing us all to be cognizant of the impact of social interactions, as well as the importance of remembering and exploring lessons that history has taught us. And also thank you to their wonderful mentors who have taken the time to guide them and shape them into such amazing candidates. Lastly, I want to say good luck to all the finalists, the essay finalists, and we would like to say thank you to our judges who are taking their time to determine the first, second, and third place winners amongst the finalists, but in my heart, you guys are all winners. It will be an immense task considering how each and every presentation was just so great. Lastly, and most importantly, I would really like to thank Dr. Mary Earle, who has been a major driving force in organizing, preparing, and giving guidance every step of the way for this event and everything else that involves the Osler Society. So similarly, I'd also like to thank Dr. Stewart, Mr. Stewart, who has been immensely helpful and responsible for handling IT for this event. So thank you very much. It would not have been possible without you because I'm very technologically challenged. So thank you all once again. I wish you all good night and I hope to see some of you tomorrow at the Osler banquet. So thank you.
And I do want to say we do have a few of the items that students spoke about out, as well as some. I know everyone wants to go, it's late, and also we're always here, so if you want to come back and see them, then please do. Thank you.